Thank you for the opportunity to present this lecture as part of the Middle East Fertility Society Exchange lecture series. So I'll be talking to you about testicular dysfunction, genetic causes, and aging. So as a brief outline, I'll be first introducing normal testicular function and normal testicular anatomy before moving on to discuss the genetic causes of testicular dysfunction and severe testicular dysfunction. We will also be discussing the detrimental effects of aging on testicular function in this lecture. And then finally, we will be concluding by discussing what the implication of any genetic problems or what the implications of aging are for our offspring. So as we know well, on a microscopic level, the testes is populated by numerous seminiferous tubules that basically contain the germ cells and the Sertoli cells, or the system that is responsible for sperm production. Now, interspersed within those seminiferous tubules is the interstitium, which contains the Leydig cells, the macrophages, and the endothelial cells. And of course, it's the Leydig cells that are responsible for the production of testosterone. And what this translates to is that on a clinical level, since the process of spermatogenesis takes around 74 days in humans with an epididymal transit time of 15 days, this basically clinically correlates to the fact that we need to wait at least 3 months for any medical or surgical intervention to have any effect on our semen parameters. And as urologists, we are actually in a very unique position to be to easily be able to examine the gonads and the reproductive organs of our patients due to the external presence of these organs. And when it comes to the physical examination of the testicle, the position of the testicle in the scrotum is very important to note. The volume of the testicle is very important, with the normal volumes being at least 15 ml. And it is also very important for us to note the firmness of the testicle, with the firmer testicle being more normal. Now, of course, all of this is very important because we know that at least 70 to 80% of the testicle is populated by germ cells, which are actually responsible for sperm production. So it is the larger, firmer testicle, which is more normal and which we expect to have normal sperm production. And it is the smaller, softer testicle, which we expect to be dysfunctional. And when we talk about testicular dysfunction, it is actually non-obstructive azoospermia, which is the most severe form of testicular dysfunction, which we encounter in our patients on a daily basis. Now, clinically, these patients with the most severe form of testicular dysfunction usually present with a decreased testicular volume, increased levels of serum FSH. They may have high LH levels and low testosterone levels. They have normal or reduced semen volumes, and this is due to a hormonal abnormality. And if these patients do end up undergoing a testicular biopsy, the results will be abnormal, with the result showing either reduced spermatogenesis or hypospermatogenesis, absent spermatogenesis or Sertoli-only syndrome, and arrested spermatogenesis or maturation arrest. Now, of course, there are numerous causes for non-obstructive azoospermia, including idiopathic causes, genetic causes, undescended testicles, testicular torsion, hormonal or medication-induced non-obstructive azoospermia. But in this lecture, we will really be concentrating on the genetic causes, which are actually the chromosomal and karyotype abnormalities and the Y chromosome microdeletions, as well as the hormonal deficiencies, or namely hypogonadotropic hypogonadism, which has been shown to have a genetic basis in at least 50% of cases. So when we talk about the most severe form of testicular dysfunction or non-obstructive azoospermia that has a genetic cause, these genetic problems usually include Klinefelter syndrome or 47XXY, XX males, XYY males, and Robertsonian or reciprocal translocations. And these are the genetic problems which are commonly encountered in patients with severe forms of testicular dysfunction and non-obstructive azoospermia. And it's actually Klinefelter syndrome, which is the most common syndrome encountered with a frequency of around 1 in 600 in our male population. And the phenotype of our Klinefelter's patients can be quite varied. I mean, they can present with, different clinical scenarios, but what is invariably true in these Klinefelter's patients is that almost all of them will have significant dysfunction in both their sperm production and in their androgen production as well. Now, Y chromosome microdeletions also constitute an important genetic cause of testicular dysfunction and non-obstructive azoospermia. Several Y chromosome microdeletions have been identified in the literature, including AZFA, AZFB, AZFB and C, and AZFC deletions. And it is very important to identify what type of deletion and what type of genetic problem is present in our patients, so that we can counsel our patients on the potential risks to their offsprings. And we will be discussing this more in our conclusions as well. So moving on to hypogonadotropic hypogonadism, which is uniquely a hormonal problem, but does have a genetic basis in at least 50% of cases. And most of these patients actually present with delayed puberty. And what's interesting about hypogonadotropic hypogonadism is that despite the fact that most of these cases do have a genetic basis, up to 10 or 20% of these patients with hypogonadotropic hypogonadism actually do recover their gonadal function spontaneously. And in most cases, this is secondary to the use of steroidal hormones. But this is actually quite interesting in terms of the fact that we do have a disease which may have a genetic basis, which may spontaneously resolve with time. So, what's very important for our patients to understand, even those that have the most severe forms of testicular dysfunction, all hope is not lost. And with modern sperm retrieval techniques and microsurgical sperm retrieval techniques, these patients do actually have good chances at sperm retrieval. And of course, prior to any intervention and prior to any IVF cycles, it's very important to counsel our patients as to the potential risks to their offsprings, given the presence of any genetic abnormalities. And when counseling couples and when counseling patients, it's very important to note that even if no sperm is found in on testicular biopsy, these patients still have a chance at achieving a family, either through the use of donor sperm or through adoption. Other couples may also discuss amongst themselves the possibility of living a child-free life as well. Again, it's very important to counsel our patients on the importance of going for the correct procedure. We all know that microtesticular sperm dissection is the procedure that really enhances sperm yield in these patients. Furthermore, we also reduce the volume of tissue excised and therefore preserve the testicles as much as possible. And it's really only with these microsurgical techniques that we are able to see these small foci of spermatogenesis and able to help our patients and provide them with the best chances of sperm retrieval. Hypogonadotropic hypogonadism is a disease that's mostly treated medically and not surgically. Most of these patients, up to 90% of these patients, will recover their spermatogenesis using a combination of injectable FSH, LH, and HCG injections and sometimes GnRH analogs. This may take 6 months and sometimes up to 2 years for sperm recovery on ejaculate. And what's important to note is that in these subsets of patients with hypogonadotropic hypogonadism, a serum prolactin level and brain imaging may also be necessary. So moving on from the genetic causes of testicular dysfunction to the process of aging. Aging is basically the transitioning from adulthood to old age, including the passing through the middle ages of 40 to 59. And as we all know on a personal level, aging leads to distinct physiological, morphological, and physical changes in both men and women. Aging is not a disease, and it occurs at different rates, both amongst individuals and within the same individuals at different stages of his or her life. Everything changes when we age: our skin, our body composition, our vision, our senses, our nervous system, our musculoskeletal system, our renal and urinary system, our GI system, and our cardiovascular system. And of course, our hypothalamic pituitary axis is not spared. Numerous impairments occur with age. The GnRH pulse decreases, the efficacy of LH in androgenesis and the efficacy of FSH in spermatogenesis is decreased as well. The pulse of LH and the pulse of FSH is also decreased. The susceptibility of our CNS receptors to FSH and LH is also reduced. So all of these things lead to a significant impairment in our hypothalamic pituitary axis with aging. And this, of course, can lead to detrimental effects both in terms of androgen production and in terms of sperm production. And actually, another theory that has been postulated as to why the HPG axis is impaired with time is the development of autoimmunity or pituitary autoantibodies against the gonadotrophs. And this has actually been postulated as an additional mechanism that contributes to the pathogenesis of age-related decline in men. Of course, the testicular dysfunction associated with low testosterone is very well known and very well documented in our literature. We all know the age-related decline in testosterone levels that starts to happen in men after the age of 40. But what is less understood is the detrimental effect of age on sperm. What we know is testicular size decreases with age. FSH starts to increase slightly, especially after the age of 40. There is a decrease in Leydig cell function and a decrease in testosterone levels. There is also an age-related decline in daily sperm production. And although the initial evidence was mixed with regards to showing no real parameter differences with aging, aside from a reduction in semen volume, more recent studies and meta-analyses do actually indicate a general decline in the traditional semen parameters with age. Furthermore, we also see an increase in sperm DNA fragmentation, an increase in sperm aneuploidy, an increase in global sperm methylation. However, interestingly, studies also show an increase in telomere length in the sperm of aging men. Now, telomeres are DNA fragments and DNA sequences that are present at the end of chromosomes, and they actually give a protective function for chromosomes during cell division. So perhaps this is a mechanism in men to compensate for all the damage that happens to sperm with aging. Of course, the association of advanced paternal age with abnormalities in the offspring was first noticed, around the 1950s, where they identified an increased risk of congenital abnormalities with advanced paternal age, particularly an increased risk of achondroplasia, but also of Apert syndrome, osteogenesis imperfecta, as well as neurofibromatosis type 1. More recently, however, especially in the last 10 to 20 years, there is emerging evidence as to the association of certain significant neuropsychiatric disorders with advanced paternal age. And I'll be presenting the evidence with regards to the association of autism and schizophrenia with regards to advanced paternal age. So autism is a disorder of neural development that leads to impaired social interaction and impaired verbal and nonverbal communication in patients and repetitive behavior. It's a spectrum disorder with a prevalence of around 1% in the US. Now, of course, one of the largest studies investigating this association was published around 2010, 2011, and it was a Swedish birth cohort study looking at around 1 million children. And in this study, paternal age was categorized as 15 to 29 as a reference category, and then compared to more advanced ages of above 30, above 40, and then above 50. And what the authors found was that there was a significant association between advanced paternal age and the risk of autism. And for sure, this risk was much more pronounced after the age of 50. Similarly, the authors of this paper also conducted a nice meta-analysis, which included around 12 previous studies on this topic. And again, the association of advanced paternal age with autism was shown, and this was particularly true in men above the age of 50. Numerous etiologies were postulated, including the increased occurrence of spontaneous genomic alterations, epigenetic dysfunction, and age-related DNA methylation changes, as well as life course toxin exposure. Similarly with schizophrenia. Schizophrenia is a disease that leads to the breakdown of thought processes and leads to deficits in emotional responses. Patients exhibit significant social and occupational dysfunction, and symptoms can include hallucinations, delusions, disorganized thoughts, and behaviors. And this disease has a prevalence of around 0.5 to 1% as per the CDC. Now, similarly to findings with autism, a large meta-analysis published by Miller and colleagues in 2010 again showed a significant association between paternal age and schizophrenia. And interestingly, in this meta-analysis, there was actually a sexually dimorphic effect, whereby there was a significant increased risk of schizophrenia in offspring of increasing paternal age, and this was particularly true above the age of 50, as well as a significant increased risk in younger fathers as well, under the age of 25. And this was after controlling for all factors as well. Again, this was further corroborated by another meta-analysis published by Torrey and colleagues around the same time, where again, the association of advanced paternal age with schizophrenia was shown. Although this association was quite modest, again, it was most pronounced in fathers above the age of 55. So what are the implications of all of this? I mean, what's the importance of the genetic testing? What are the implications of advanced paternal age? Well, to begin with, genetic testing is very important. It's very important to counsel our patients and to identify the cause of testicular dysfunction in our patients. And it actually helps our patients understand their disease. Genetic testing is also very important because it can help us counsel these patients as to their chances of sperm retrieval. For example, there are multiple Y chromosome microdeletions that have been found. And one of these microdeletions, which is the ZFC deletion, actually provides these patients with quite good and acceptable chances at sperm retrieval. So again, that's why it's very important to identify genetic problems in our patients so that we can counsel them about their chances of sperm retrieval, and so that we can counsel them about potential passing on these genetic problems to their offspring as well. Now, with regards to advanced paternal age, this is definitely something that has been interesting us in the literature over the past 10 to 20 years. We all know in our clinical practice that both men and women are choosing to start families at a more advanced age. So this is why, as urologists, it's very important for us to understand what the implications of advanced paternal age are, so that we can counsel our patients on how to, safely start their families. So thank you for your concentration during this lecture, and thank you for your attendance, and I'll leave the floor open to any questions.